Now I invite Dr. Vijay Viswanathan to deliver a lecture on biomarkers for diagnosing complications. Dr. Vijay.
Professor Madhavan and Dr. Shanmugam, I'll finish my talk in 10 minutes because we are about 10 minutes behind schedule. I'd like to thank Dr. Vijayakumar for this invitation at this late hour. Anyway, it's in the T20 match, it's always the last over is most interesting, and Chennai is famous for that. What I'm going to talk to you in the next 10 minutes is data from the Professor M. Viswanathan Diabetes Research Center. It's not from the textbook. And what I'm going to talk to you is something which pertains to the kidney and the foot, where we have done some work. Now we know that diabetes affects the kidney, and the microvascular complications are very much related to blood sugar levels, okay? Whereas macrovascular complications may not be related to the blood sugar levels. But if you can see here, the kidney and the neuropathy and so on are very much related. This mouse is not working. Okay, I thought the mouse is working. This mouse won't work? It won't work, huh? No, the mouse is working here, but it's not showing there. Okay, no problem. No problem. So you can see the microvascular complications are a total function of diabetes. Okay, so what I'm going to say to you might be little astonishing. And I'm going to talk to you about two complications, one with respect to diabetic nephropathy and one with respect to amputation. Now we know that all these are risk factors, all that is known, but what I'm going to focus, again I'm showing the mouse, it's not working. So what I'm going to show to you is, this also is not working. So I think everybody is fatigued, even the mouse is not working. This is not working. Everybody is fatigued and waiting for dinner. Not that, man. The mouse. It's okay, leave it. Because I have to finish and keep up my promise of finishing in 10 minutes. It's okay. So the genetic predisposition is a very important component. So though we talk about diabetes, blood sugar, blood pressure, I'm going to focus in the last 8 minutes on genes and whether you get kidney disease or amputation actually depends upon genes. So that's what I'm going to talk to you in the next 8 minutes. Now, why is it important to prevent kidney disease? So this is a study which we published 5 years ago in the Indian Journal of Nephrology, where we showed that an ordinary Indian cannot afford to have dialysis on transplantation. So this was a study for which a nephrologist from the UK, Birmingham, actually wrote an editorial. So an ordinary Indian cannot afford dialysis and transplantation. And only about 2% are fortunate enough to have a kidney transplant or dialysis going on and on and on. The remaining 97 will die of uremia or of a cardiovascular disease. Now we showed some time ago that the cost of diabetes therapy is 2 times if you have diabetes and hypertension. So why I'm showing all this is just to show you that we need to prevent diabetic nephropathy and foot amputations. So let's talk about the biomarkers. So this was the first gene which we looked at, the Sdf Gene Polymorphism, which is situated in chromosome 11. And we had 2 papers, and this was the latest paper where we showed that if you have the D allele, there is 2 alleles, the deletion allele and the insertion allele. If you have the D allele of this Sdf gene, then you will have a faster progression of diabetic nephropathy than somebody who has an I allele, insertion allele. So if you're able to check, if your patients are interested, you can ask them to check the Sdf gene whether they have the D allele or the I allele. If they have a D allele, they may not respond to your losartan, to your azilsartan and so on, because they have higher levels of ACE inhibitors, ACE enzymes, and they do not respond. So this is one study which we did some time ago. The second is an important concept of transforming growth factor beta. Now, it has been shown that the transforming growth factor beta is an important mediator of the high glucose-induced effects on the renal tubular and mesangial cell growth. And one of our PhD students, Mamta and I, about 15 years ago, looked at the TGF beta gene as well as the levels of the protein in people with nephropathy and without nephropathy. And I'm just showing you one slide. If patients who took insulin, in addition to oral drugs, this was about 15 years ago, there was no SGLT2, there was no gliptins, there's nothing. So we found that those who were on sulfonylurea, metformin, and insulin, I would have loved to show it in a slide, but everybody is tired. No? The pointer is tired, the mouse is tired. So if you have both insulin and oral drugs, you can see that the level was lower among patients who took insulin. And among patients who took the ACE inhibitors or ARB, at that time I think we had losartan and telmisartan I think we had, versus patients who did not take ACE inhibitors, you can see the statistical difference. So TGF-beta levels come down if you use insulin and if you use ACE or ARB. And the probable mechanism is on the TGF-beta. Next, another PhD student, Priyanka Tilak from Mumbai, she was a type 1 diabetic who did her PhD in diabetic nephropathy, looked at the MCP. The MCP is not male chauvinistic pig, which we use in common language. MCP is a very important, strong chemotactic factor for monocytes and is upregulated in diabetic nephropathy. The second line you can see. Therefore, we measured the urinary MCP1 and we found that it was very important, and we found in this particular study that as the EGFR fell, the urinary MCP level expression was more. So if you are able to measure urinary MCP level in addition to albumin, because today we say albumin is not a very good marker, EGFR is not a very good marker, and so on. You should have both. But if you have additional, these are all research tools. I'm not saying tomorrow you should ask which lab is going to do the urinary MCP, but I'm just, because Dr. Vijayakumar asked me to talk, and Dr. Vijayakumar, thank you for this invitation. I forgot to thank you in the beginning. So if you are able to measure the urinary monocyte chemoattractant protein level, we found that it is a very important marker for decline in kidney function, not for patients, for predicting who will get kidney disease. For that you need the ACE gene and so on. But prognostic marker of which patient will slide down to kidney disease and kidney failure and who will go slowly. So these are the 2 points. And then this is important because the Credence study is based on this. So some years ago, one of our PhD students, Damodaran, did this. He looked at different stages of nephropathy, and we found that the circulating TNF alpha was associated with a particular gene called the TNF alpha gene in diabetic nephropathy. Now, the Credence study showed that there's a lot of hot news about Credence study, and this paper is just published this morning. I picked it up this morning, that canagliflozin actually protects the kidney by reducing the inflammation and fibrotic markers, especially if you read the lines, you'll see the TNF alpha. So the TNF alpha is overexposed, over manifested, upregulated in diabetic nephropathy, and canagliflozin just reduces the inflammatory marker. So TNF alpha is an inflammatory marker, and canagliflozin, if you give for patients who have albumin and higher levels of TNF alpha, you can actually reduce it. So this is probably one of the mechanisms of action of cana. This is a very important marker, the urinary liver type fatty acid protein. Now you can see that this urinary LFABP is a tubular function. We always think diabetes is a glomerular disease. So we showed in this study that this particular binding protein called urinary liver type fatty acid binding protein increases, the levels increase as your kidney disease gets worse. So it was higher in patients with microalbuminuria as compared to normoalbuminuria, and it was associated with declining renal function. It costs about 150 rupees to do one test, because we had, I don't know how many patients, about 85 patients, and it costs about 150 rupees. There are some advanced labs which do the urinary liver type fatty acid binding protein, LFABP, and this is a very good prognostic marker. So albumin, EGFR are all good. I'm not saying it's not good, but what I'm trying to say is these are additional markers which, if you have somebody whose father died of kidney disease and mother died of kidney disease and a very strong genetic family history, you can probably think of doing these biomarkers. And this is a cytokine. So we found that YKL40 is a inflammatory cytokine which is associated with diabetic nephropathy. Having said that, we published this very good study in the Indian Journal of Medical Research, which is the official journal of the ICMR, where Priyanka showed that if you follow patients for 12 years, what happens? So we took two sets of patients. No, we had one set of patients who had no albumin in the urine to start with, and she did a 12-year follow-up, and we found that some patients developed nephropathy, some patients did not develop nephropathy. So progressors and non-progressors. And she found that the baseline HbA1c, the mean HbA1c throughout these 12 years, presence of diabetic retinopathy, triglyceride and systolic blood pressure. Only 4 came out important for kidney progression. Triglyceride, systolic blood pressure, not diastolic, presence of retinopathy, HbA1c at baseline and HbA1c during follow-up. So having said about all the genes and ACE gene and all that, we should remember from this study, which we published some years ago, that ultimately it is the kidney prevention is in our hands. We should control the diabetes and blood pressure and triglyceride and lipids of our patients who have albumin, right? So you can't just say, oh, it's in your genes and you are destined to die. No, the responsibility is equally. So that's why I projected this slide at the end. Let's not say, oh, you died because of genetic, your father passed on your genes of kidney disease and so you died. No, we have no excuse. We physicians have to treat the diabetes and so on. Last 3 minutes, there are not many biomarkers, but we did catch some biomarkers because we think diabetic foot is all because of neuropathy, peripheral arterial disease, walking barefoot, and so on. That's what we have been talking all these years. But we found that, and you know that this study which we did across India, 31 diabetologists, which we published in JAPI, we found that the main cause for amputation was infection. That's known, okay? But what I'm going to show you is the Sdf gene polymorphism. What is SDF? SDF is a stromal cell-derived factor, SDF1 alpha, and they're small cytokines that belong to the chemokine family. And if you give hyperbaric oxygen, you can actually reduce stromal cell-derived factor plasma levels. They activate leukocytes and are often induced by pro-inflammatory stimuli. And it is associated with major amputation. That's what we found in these 2 studies. So there is a very strong association. So not everybody with neuropathy will end up in an amputation. If you're interested, which of your neuropathy patients will end up in an amputation, there is a gene polymorphism, SDF1 polymorphism, which you can estimate in blood, in plasma, using ELISA method. Okay, it costs about 180 rupees or so. And there are also some chemokine genes which are associated with amputation. Then Damodaran also showed that there's something called a heat shock protein. It is a very important component we showed in this paper, that it's associated with diabetic foot ulcer. So what I'm trying to say, what I was trying to say in the last 10 minutes was that you have a diabetic patient. It's our duty to check for albumin, neuropathy, and all that. Okay? Treat his diabetes, blood pressure, give him proper footwear and all that. All that is there. It will prevent his retinopathy, nephropathy, and neuropathy. It will prevent an amputation. But remember that there is also a genetic component. So all that you do for the patient may not always end up in success because there is a strong genetic component involved. We should remember that. So if our treatment is not working, if you have given ACE inhibitor to somebody and the kidney is simply falling down, right, you should think of some genetic polymorphism and you should refer to a place where they do gene polymorphism. ACE gene, the urinary fatty acid binding protein, the MCP gene polymorphism, and for foot, it is the SDF gene polymorphism. If you can remember these 4, I think I have made my day today. Thank you, Dr. Vijayakumar, once again for this invitation.